So hopefully this session, I don't think it's going to take more than half an hour. It's quite a short topic. Yeah, so we're just going to quickly go over the etiology, pathogenesis, the signs and symptoms, treatment, and diagnosis. Um, and yeah, we'll have some questions along the way and some SBAs. If you do have any questions, just do put them down in the Q&A part. Okay, so a 40-year-old man is investigated for back pain. For the past few months, he has been trouble with pain in his lower back, which is typically worse in the morning and gets better by the end of the day. But there is some radiation of his pain to the right buttock, but no leg pains. On X-ray of his lumbar spine, this is what it looks like. So from the X-ray, what is the most likely diagnosis? Please do leave your answers in the Q&A part. One second. Yeah, very good. So this bamboo spine appearance is very characteristic of ankylosing spondylosis. So it's very textbook. So it is quite a late manifestation, which you'll see in the X-ray. So we'll go through all the X-ray findings later on. But yeah, so if anything you learn from today, hopefully you can just correlate bamboos with ankylosing spondylitis. So why is it not a vertebral fracture? It's going to be more acute. There's not going to be any variation throughout the day. Osteoporosis is pretty much thinning of the bone. So it's not going to cause any pain, but it just makes the bone more unstable. And the pain will only come when there's an actual fracture. So the fractures you do see are crush fractures most commonly, especially in the thoracic spine, not in the lumbar. And then spinal stenosis, again, you can't confirm spinal stenosis with an X-ray. You need an MRI, but it is a good differential. And then this lumbar disc prolapse is similar to vertebral fracture. It's just not going to be any diurnal variation. It's going to be more acute, and yeah. So this X-ray is very characteristic. So yeah, it's quite clear, the bamboo appearance, but this particular X-ray is on a very late stage ankylosing spondylosis. So I couldn't find one which is for a 40-year-old, which I can legally put in this presentation. So ankylosing spondylosis is a seronegative chronic inflammatory arthritis involving the axial skeleton. So unlike the other arthritis, which I was speaking to previously, or the rheumatic conditions, this one affects more males than females. So in the younger age group, the 20s to 40s, and also other disease names for it is Mary-Strumple disease or von Brechtero's disease. So the etiology, so there's actually no known etiology. So this is just there for theoretic purposes. So there is this genetic predisposition if you have HLA-B27 positive. So a lot of 90% of the ankylosing spondylosis patients have HLA-B27 positive. But again, even if it's negative, you can still have it. And then this environmental factors is not much known, but yeah, this infection with Klebsiella pneumoniae does have common incidence with ankylosing spondylosis. So the pathogenesis, so hang on, let me just adjust these slides. Okay, just move this out of the way. Okay. Yeah, so pretty much this autoimmune reaction against the intervertebral joints and the facet joints. Again, yeah, genetic, but we don't really 100% know the exact etiology for it. Then this will cause a release of the cytokines by the neutrophils within the joint space, and specifically tumor necrosis factor A and then interleukin-1. This will cause joint destruction over time. The continuous joint destruction will lead to the fibrin deposition by the fibroblasts in the destroyed joint areas. These fibrous bands will limit the joint movement, and eventually the areas where the fibrin deposition there's going to be activation of osteoblasts where the fibrous deposition happens. So this will start the bony changes, which we'll discuss later on, specifically in the what's it called? In the annulus fibrosis. So in your intervertebral space, the joint mainly composes of the annulus fibrosis and the nucleus pulposus. So the nucleus pulposus is this jelly-like substance, which pretty much is what bulges out whenever there is disc prolapse. So what's surrounding is that annulus fibrosis, which pretty much gets deposited with the fibroblasts, which will give rise to syndesmophytes, which we'll discuss later on. So yeah, the clinical features, back pain for at least 3 months, early morning stiffness for more than 30 minutes, which improves as the day goes by. The patient may wake at night because of the pain, mainly because of the stasis. And then the buttock pain if there is root compromisation. And then enthesitis, which is pretty much the inflammation of tendons. So commonly involves Achilles tendons and also in the tendons of your wrist. Then reduced chest expansion and limited lateral bending. So with the limited lateral bending, they used to do something called Schober's test. So Schober's test is pretty much you draw a line 5 centimeters above the dimples on your back and 5 centimeters below, and you ask the patient to bend down. And if the expansion of that line is not more than 5 centimeters, then yeah, it is positive. So commonly involved joints, the intervertebral joints, sacroiliac joints, and the facets. So deformities later on, like this diagram, which I found, it's just a chin on chest deformity because of the severe kyphosis. So the next one, so which one of the following is least associated with ankylosing spondylosis? So apical fibrosis, Achilles tendonitis, amyloidosis, heart block, and achalasia cardia. Leave your answers in the Q&A section. To give you a clue, there's 6 A's. That's the complications of ankylosing spondylosis. 6 A's, ankylosing spondylosis. Memorize that. Okay, so it's not heart block. Uh, okay, so yeah, it's achalasia cardia. So the 6As, which are the complications of ankylosing spondylosis, includes apical fibrosis, anterior uveitis, aortic regurgitation, AV node block. It can cause other heart blocks as well, and Achilles tendonitis and amyloidosis. So only this achalasia cardia is the odd one out. So yeah. Okay. Moving on. So yeah, these are the main systemic manifestations. There are a bit more, but the main ones are the 6As. So yeah, just the anterior uveitis, iritis, AV block, aortic regurgitation, aortitis, other complete heart blocks, apical pulmonary fibrosis, psoriasis, inflammatory bowel disease, renal amyloidosis, and colitis. Okay. So the next SBA, hold on, let me do this out of the way. So this 30-year-old man is investigated for chronic back pain. Which of the following will most suggest ankylosing spondylosis? So loss of thoracic kyphosis, pain on straight leg raising, accentuated lumbar lordosis, pain which gets worse during the day, and reduced lateral flexion of the lumbar spine. So yeah, just put your answers in the Q&A section. So yeah, the reduced lateral flexion, sorry, spelling mistake, flexion of the lumbar spine. So that's one of the earliest signs of ankylosing spondylosis. We'll go over the good diagnostic criteria for the coming slides. So the loss of thoracic kyphosis, so thoracic kyphosis will be more pronounced in ankylosing spondylosis, if anything. Pain on straight leg raising, yeah, that is one feature, but that comes later on, especially when the nerve roots are involved. But it's not specific to ankylosing spondylosis. And then accentuated lumbar lordosis. Yeah, lumbar curvature is less pronounced. Like how I was talking about earlier regarding the Schober's test. So if the lumbar lordosis is more accentuated, then that will pretty much is the opposite of what the Schober's test does. So it pretty much gives you a very stiff lower back. And then yeah, pain gets worse during the day. No, it gets better with movement. It's as it's an inflammatory arthritis. So yeah, so with the X-ray findings in the vertebrae, yeah, so initially you can see the squaring of the vertebrae, these vertical syndesmophytes. They just pretty much imagine them as horns on top of the vertebrae. And then yeah, in the sacroiliac joints, there will be autofusion over time. And then bamboo spine, just like this image. And then this yeah, in the sacroiliac joints also you can see these erosions and what you call sclerotic lesions. So the diagnosis, so the easiest way to do this is especially in the primary care, is using modified New York criteria. So yeah, low back pain for more than 3 months, which is improved by exercise, but not improved by rest. There's limited lumbar spine motion on the sagittal and frontal planes, and then limited chest expansion. And on top of that, with X-ray findings of sacroiliitis on the X-ray. So yeah, so if the radiological criteria is present and at least one of these clinical criteria is present, then you can diagnose that. Otherwise, it will be probable if all three of them are present, but there's nothing in the radiology findings. Okay, so pretty much just remember back pain, limited motion, and limited chest expansion. So the pharmacological treatment, unfortunately, there isn't something drastic, but yeah, just NSAIDs, ibuprofen, naproxen, and if it does get very, very severe, then yeah, opioids. In that case, you will have to refer on, and hopefully they'll be in online with at least getting a DMARD or the surgery organized. So the DMARDs that we use are mainly infliximab and adalimumab, just mainly just for the tumor necrosis factor inhibition. So like I discussed in the pathogenesis, the tumor necrosis factor plays a big role for the inflammation and also for the sequence of events. Surgery, joint replacement, especially for the hip. So over time, the hip mobility is going to be really compromised, and then it's just going to make the joint more congruous. And then vertebral osteotomy may help symptoms, especially if they have radiating pain and a nerve root involvement. Then nearly done. So just a short webinar today. So yeah, I think the second last SBA. So yeah, so a 30-year-old man comes in with many months of lower back pain and stiffness, which is worse on mornings. He finds the symptoms which improves after exercise, but worse when he's sitting on his office doing his work. And on exam, there's very limited lumbar flexion with sacroiliitis on his X-ray. What is the most appropriate management? So here you go. You can put your answers in the Q&A section. Yep. So yeah, NSAIDs preferred drug for management. Yeah, along with this, you refer them to physiotherapy. Yeah, and then obviously infliximab is for severe ankylosing spondylosis. So usually this will be started by the rheumatology team. And yeah, this will definitely be later on when NSAIDs are not effective and the opioid use is too high. There are sometimes patients with oxycodone taking 15, 20 milligrams modified release daily. So for these patients, it's just too much opioid use. But unfortunately, they can't immediately put them on the surgical waiting list. So, or they'll be waiting for a rheumatologist appointment as well. So, yeah, so for these patients, yeah, they tend to suffer quite a lot. So paracetamol is not going to do much, especially for ankylosing spondylosis, and allopurinol and colchicine is mainly used for gout. So it doesn't really have a role here. And yeah, that's about it. So hopefully you guys enjoyed that tiny webinar, and please do leave some feedback. I'll really appreciate it. Next fortnight, we'll be talking about pain relief. That's quite important for any doctor, any PA, any nurse, anyone pretty much working in healthcare center. It's So yeah, that'll be a bit longer. But yeah, do let me know your thoughts, and yeah, please give feedback. Thank you.